Chapter 1 is addressing the concepts and the trends in the healthcare system currently existing in the United States. Please take a moment and review the learning objectives for this presentation. You may need to stop the presentation for doing that. Let's look a little bit to the roles that the nurses are handling in the delivery of healthcare. Nurses have a multitude of roles, and those roles are most of the time very complex. Nurses are expected to collect data, to diagnose expected responses to health issues, to plan and provide care, and as well to evaluate the outcomes of the care provided. The nurses will work in a variety of setups and will work by following the facility and the state policies. Nurses are expected to educate clients and families and as well as staff. They will manage resources and most of the time will act as an advocate for the clients. In addition to that, nurses are active participants in disease prevention and health promotion activities for the clients, families, and communities as a whole. If we define before the wellness and the health, let's see now what does it mean illness and what is the difference between illness and disease. So if we are talking about the illness in a very theoretical way of looking at it, that represents the state of being sick. So in other words, most people will see illness as something very sudden, acute. It can be as well chronic in other conditions, or for others, it can be considered terminal. Compared with the illness, disease will refer to a pathologic condition of the body that presents with some clinical signs or symptoms, and will have some lab values that will change in accordance with the considered disease. So if we're looking into that, the major difference between illness and disease is that the illness is highly individual and personal, where the disease is something that is more general, measurable, and we can compare a disease from one person to the other. If I need to give you an example, a client with arthritis will have some distinct pathologic changes associated with a disease. However, this person with arthritis may not be ill. The degree of pain and suffering or immobility will vary between one patient to the other. We'll look now into the concept of health-illness continuum. So instead of looking at the pure definition of health and illness, we can look at what is a health-illness continuum, which can be defined as a level of health. It's a continuous change that we are going through, every single one of us. So this continuum illustrates the process of change, while an individual will go through a variety of states from health to illness and back. And this range can span between extremely good health to extremely sick, or in other words, death. We'll discuss now the concept of health maintenance and promotion. We live in a society where we believe nowadays that we are and are able and are actually in control of our well-being. And we are learning how to take responsibility more for our health status. The health maintenance refers to the process of protecting one's current level of health by preventing illness or deterioration, by complying with medication regimens, by screening for certain diseases such as breast and colon cancer, and definitely practicing safe sex. Health promotion, on the other hand, refers to the engagement in strategies to enhance health. So some of those strategies will be, let's say, eating diets that are rich in fiber, that are rich in complex carbohydrates and low in fat, to have a diet that is high in fruits and vegetables, exercising on a regular basis, and balancing work with other activities. Now we have a third element here, the illness prevention, and this will be that will involve identifying the risk factors, such as identifying a family history for hypertension or diabetes, and address that with individuals that do not have the condition yet on how to prevent it, reducing the risk factors in a multitude of other conditions, including cancer. In addition to that, we have what is called the early detection, and early detection refers to the screening for diseases by performing certain tests and procedures that will identify a disease even before it's giving its signs and symptoms. For health maintenance and promotion, we need to have our clients as an active partner. Back in the day, the healthcare services were received in a very passive way. Nowadays, we are not using anymore the term of patient, but we use the term client. And this will, in other way, will reflect the way that we are seeing our patients. They are a partner. It reflects their attitude and their personal responsibility and the way that they need to be involved in their health. In addition to that, we use the term client because those individuals may or may not be ill. And that's why patient is not a term that is currently a correct one. Now let's look a little bit into the healthcare system. And when we're doing that, the concept of health changed in the past decades. And along with the way that the concept of health changed, the healthcare system changed along with it. There are some rapid advances in science and in technology. And as a result of that, we have the development, we succeed to have highly sophisticated methods of diagnosis and treatment for a wide variety of conditions. So, in other words, the healthcare system is growing and currently includes a multitude of setups, including outpatient, short-term, long-term facilities. And along with that, there are escalating healthcare costs. And because of those escalating healthcare costs, we are looking into shortening the length of hospitalization. And not only because of the cost, in addition to that, we know that it's beneficial to our clients to be outside the facility as quick as possible. Question 1. The view that health and illness exists on a continuum is not just a nursing concept. It runs throughout the professional healthcare system. What does this view aid in the nurse's understanding of health? And you have 4 options. A, that care should focus on the treatment of disease. B, that the person's state of health is ever-changing. C, that the person does not have varying degrees of illness. Or D, that care should focus on the patient's response to medication. The correct answer is B, that a person's state of health is ever-changing. And the rationale for that is that fact that when we see health and illness as a continuum, we now understand why a person is never completely healthy or never completely ill. Instead, this person is in a fluid state that is ever-changing and has a potential to range from high levels of wellness to extremely poor health. Let's take a look now to the healthcare team and who are the individuals that are part of the healthcare team. Per definition, a healthcare team will be made up of specially trained providers that will all work together having a common goal, that of helping the clients to meet their healthcare needs. And you have an example in this picture of what will be the individuals that you will see in this team. They will be your physicians and nurses and psychologists and pharmacists, dietitians, social workers, respiratory and physical therapists, occupational therapists, nursing assistants and technicians, and not the last on the list, the insurance company staff. We'll describe the healthcare delivery system now. And when we are talking about healthcare delivery system, we refer to the full range of services that are available to the people seeking either prevention, identification, treatment, or rehabilitation of health problems. When we are looking at this system, we can split it in several levels. We can have a range of services. The first resource person or agency that the client can come in contact when in need for healthcare will be the primary care provider. And that would be a family healthcare provider, an internist, or a nurse practitioner. In this setup, the emphasis is on health promotion, prevention care, health education, early detection, and treatment. The next level will be the secondary care, and this will include the facilities that have capabilities for additional testing, such as cardiac catheterization or consultations and diagnosis, emergency and acute care interventions. Now, the third level for that will be a little bit more complex, and it's called the tertiary care, and will include those places capable of having the ability to offer complex medical and surgical intervention, cancer care, rehab services, long-term care such as burn care or hospice care. Now, in addition to their roles at the settings already mentioned, the nurses will provide care in other setups, and we'll describe them in a second. Question number 2. The client who is complaining of back pain has scheduled an appointment with a family practitioner. What type of care is the client receiving? A, acute care. B, primary care. C, secondary care. Or D, tertiary care. The answer is B, primary care. The first provider that the client will contact about the health need will be the primary care provider. Typically, will be a family practitioner or a nurse practitioner. Now, I was telling you that the nurses, in addition to those primary, secondary, and tertiary care, will provide services in other setups that are called adjunct healthcare settings to inpatient care. Those will be skilled nursing facilities that will offer prolonged health maintenance or rehab services. Those can be long-term care or extended care facilities. And for example, we can discuss here nursing homes, skilled nursing facilities, rehab centers, subacute care units. In addition to that, nurses will be found providing home care, which is extremely important adjunct to inpatient care. By having those visiting nurses and by being able to offer the home health aides, we are able nowadays to provide early discharge to home and still provide all the services needed. Another setup will be the hospice and home hospice care that are providing resources for terminally ill clients and the families. Let's discuss now what is the access to care and what does it mean. In 2010, the Patient Protection and Affordable Care Act, PPACA, that most often is seen and shortened to Affordable Care Act, ACA, was passed and is also known as the Healthcare Reform or Obamacare. And through this act, affordable health care was designed to be provided to U.S. citizens that previously had no access to health insurances. Prior to this act, almost 50 million Americans had no access to health care, which will represent roughly 16% of the population. The estimation for 2015 was that the number of uninsured dropped will be about 9%. The overall goal of healthcare reform was to provide affordable healthcare to most or more U.S. citizens. Another goal of this reform was to reduce the insurance company's control of healthcare and to provide more assistance, especially for those categories that need the most the help as senior citizens that were on a fixed income. There is a lot of controversy surrounding the PPAC, and the future is still unknown. Despite over 50 attempts to repeal the PPAC, it still remains the law. However, its implementation was never fully occurred, but most of the measures are still in place. Now, we need to look at the financial costs of the healthcare. And historically, when we are looking at the financial costs, the private insurance, self-insurance systems, and Medicare were paying for the healthcare. The hospitals and the approved providers will receive payment for what they charged, and more charges, meaning more revenues. Now, we'll look into that when we are moving to the next slide. Let's look into what happens with the government-funded healthcare. Well, in 1965, the federal legislation created what you know by now as Medicare and Medicaid, and we'll describe each of those. Medicare represents the federally run program that is financed primarily through employee payroll taxes. It will cover individuals who are 65 years of age or older. Those that are permanently disabled at any age with specific disabilities, and persons with end-stage renal disease. And when we are looking at Medicare, they do have, the Medicare has several parts. And it's good for you to have an idea what those parts mean. So let's try and describe them. Part A, Medicare, will cover hospital care, skilled care, nursing homes, may require the participants to pay a monthly fee for this coverage if they did not pay Medicare taxes when they were working in advance. In Part A, all participants may have to pay co-payments, co-insurance, or may have deductibles. Now, Part B of Medicare is looking and covers the medically necessary services such as physician services, outpatient care, home health services, and other selective services that are not covered under Part A, and this Part B will include preventive services. It may require an annual deductible, and after the deductible is met, the participant will pay 20% of the Medicare approved amount of the service or a monthly premium unless the participant has another type of insurance. Part C, which is also called Medicare Advantage Plan, will include Part A, hospital insurance, and B, medical insurance, and sometimes Part D, that is the prescription drug coverage, Part D drug. The private insurance companies approved by Medicare who are able and allowed to manage this type of plans and may implement it in different ways by having different levels of premiums, co-pays, insurance, co-insurance, and deductibles. So in other words, you have Part A, Part B. Part C is a combination of Part A and B, and sometimes may include Part D as well. And let's see Part D. Part D is the prescription drug coverage, and it helps with the coverage and possibly reduce the prescription drug costs. And by doing that, protects from any type of catastrophic drug expenses. So clients on Social Security will automatically be participating in Part A, where the other parts are optional. Medicare is primarily developed and is considered for older Americans. However, it does not cover custodial or long-term care and limits the coverage for health promotion and illness prevention. The increased costs of Medicare that were connected with a decrease in the benefits make this program nowadays extremely expensive for many older adults. And those people with adequate resources may purchase what is called private Medigap insurance policy to cover other expenditures such as co-payments and deductibles if needed. Let's look into Medicaid now and see what Medicaid is. So Medicaid is are programs that are administered by each state. So the difference between Medicare and Medicaid, mainly, if we start by compare and contrast Medicare, federal, Medicaid is administered by each state, and they will follow the federal requirements and will be funded jointly by the state and the federal government. Medicaid will provide health coverage to individuals and families with limited incomes and resources. And the mandatory benefits that will be included by Medicaid are inpatient and outpatient hospital services, screening, diagnostic, and treatment services, home health services, physician services, rural health clinic services, federally qualified health center services, lab and x-ray services, family planning services, nurse midwife services, certified pediatric and family nurse practitioner services, freestanding birth center services when licensed and recognized by specific states, transportation to medical care, and tobacco cessation counseling for pregnant women. So you see, it's a long list and includes a lot of the essential services that every single one of us will need. There are some optional benefits that vary from state to state and may include services as clinic care and physical and occupational therapy, speech therapy, complementary services. Now we have another type of government-funded healthcare, and this is called the Prospective Payment System, or PPS. Let's see what this system is. In 1983, Medicare implemented another system that is called the Prospective Payment System, and that was done as an attempt to control costs. This is a method of reimbursement in which the healthcare provider receives payment for services based on predetermined or fixed rates. So the payment amount for a particular service is defined by a classification system of that service. And the classification system for the inpatient hospital services uses almost 500 diagnosis-related groups. And they are clustering, they are grouping the services for clients with similar diagnosis. For example, if you have a client that has a hip, knee, or shoulder replacement, they all fall into one category of DRG. And that DRG category will be total joint replacement. And those surgeries, regardless of the type of the prosthetic used, the length of the surgery, the length of the hospitalization during the surgery, will be reimbursed at basically at the same rate. Private insurers may use DRG, or they may use other classification systems for reimbursement. However, PPS are largely responsible for the decrease in the hospital length of stay since the early 80s. Let's define managed care organization and what those are. The managed care organization are insurance companies who carefully plan and closely will supervise the distribution of healthcare services. So in other words, it is a business that will put its emphasis on cost of service and economic use of resources. And they will manage care by focusing on prevention and maintaining the healthcare at all costs. We have two most common types of managed care system, and those are health maintenance organizations, or HMOs, and preferred provider organizations, or PPOs. There are two other models, and those will be point of service, or POS plans, and physician hospital organization, or PHOs. And you'll be amazed, but those last two are becoming more and more predominant nowadays. And we'll define each of those. Let's look into the HMOs. HMOs, or health maintenance organization, are represented by a group of insurance plan. It's a group insurance plan in which participants pay a preset fixed fee in exchange for the health services that they receive. The fee is not based on the number of services provided, but rather is projected by the number of participants and the expected services. In other words, this type of management is referred to as capitation, refers to the actual head or person count. The physician will have an incentive to keep costs low because the fee paid to the physician remains the same regardless of the actual services or frequency of care provided. The financial stability of HMOs is based on their ability to keep their members healthy and out of the hospital throughout periodic screening and health education and preventive services. The participant fees will cover all medical costs incurred and are paid regardless of whether member requires healthcare services. If they do not require high-cost care, providers will make money. If the members, on the other hand, will become extremely sick and they will require high-cost resources, the provider will lose money. So you can see now how the HMO, they have this incentive of putting their efforts into maintaining the health of the insured people. So HMO will provide what is called ambulatory, hospitalization, and home care services. Some of the HMO companies will have their own facilities, others will use the community agencies for services. The members of an HMO, on the other hand, they must receive a referral, an authorization for secondary care, such as a second opinion from a specialist or certain diagnostic tests. If members obtain unauthorized care, they may be held responsible for the entire bill. As opposed to that, let's see what is the preferred provider organization, or the PPO. This one now operates on the principle that competition can control cost. The PPO creates a community of network providers who are willing to discount their fees for services in exchange for a steady stream of referred customers. In other words, the providers will still make money as long as they are getting more and more patients. The consumer, the client, can lower their health costs if they receive care from one of those preferred providers or the system, the providers in the system. If they select providers outside the network, they will end up paying a higher percentage of the costs. Point of service now. The point of service organization will have a network of providers as well. The client will select the primary care physician within the group, who then will become the gatekeeper for other healthcare services. The client can use the healthcare providers in or outside the provider group, but that will be with an additional fee. And the additional fee can be a higher deductible, a co-payment, and whenever they are using the inside providers, the fees will be lower. The benefit for the insurer will include discounted services, reduced services, and elimination of any unnecessary referrals when we are considering the point of service. The last type of managed care is the physician hospital organization, and they are the result of financial concerns of hospitals and physician practices. This type of organization creates a corporate structure between hospitals and groups of physicians. They contract with the MCOs to negotiate fees for services. Again, MCOs are the managed care organizations, which are insurers, to negotiate their fees for the services, and those will be especially for their self-insured employees. And the goal for that is to maintain high-quality services as well as containing the costs while fostering group contracts and collaboration. In other words, you see that regardless of which type of managed care organization we are looking into that, they are all thinking about the same thing. How can we contain costs? And the easiest way of containing costs will be by maintaining a higher level of well-being of the clients that are insured. It's easier and costs less money to screen and identify a condition at an early stage instead of waiting until it's full-blown disease and we need to now address it with a wide range of diagnostic tests and treatments. Question number 3. Managed care organizations are insurers that carefully plan and supervise the distribution of health care services. Because of managed healthcare, there have been significant changes in the healthcare delivery system. What is one major effect? A. Patients are in the hospital for a longer period of time. B. Patients are committed into negotiated payment rates. C. Patients are being discharged with complex home care needs. Or D. Patient use of ambulatory care has increased. The answer is C. Patients are being discharged with complex home care needs. And the rationale for that is the managed care has contributed to a reduction in inpatient hospital days, which results in clients discharging with more healthcare needs, and many of which are complex and can be managed at the patient's home. Let's discuss now the changes in trends that are related to cost, or in other words, those that are cost-driven changes. So there is a shift in the economics and the decision-making power at the level of the hospitals um, due to the changes in the way that the reimbursements are performed, and as well as the changes at the level of the practices. So there is a lot of concern and a lot of criticism um, that will refer to the uh, mainly from the consumer's part, that they are unable to obtain the care that the health care that they expect and at a fair price. So as a result of the managed care influence, the hospital starts to do what is called a downsizing. They will restructure or in sometimes even close their facilities. In consequence, there will be a lot of regions that will be left with no hospitals, fewer hospitals, with a higher nurse per client ratios, with a higher client acuity level on general medical surgical units. And all those changes will have an impact on an economic level. Changes in the healthcare industry will affect and are affecting as well the healthcare workers. So nowadays, the hospitals will employ unlicensed assistive personnel in order to perform those duties that back in the day, practical and registered nurses, again, practical is the vocational nurses for the rest of the country except for California. Practical and registered nurses once provided, and now they're performed by unlicensed assistive personnel. There is a certain concern regarding the fact that unlicensed personnel may jeopardize the quality of care because of the very restricted and not extensive preparation that they have. In addition, the physician's income decreased in the recent years, and this is a trend that will most likely continue. And this can be attributed in part because of the growth of nurse practitioners and physician assistants that can perform and can provide very high quality healthcare services at lower prices. So there is a predicted decrease in the income that will lead fewer men and as well women to enter the medical profession at all. It is obviously that the rural areas are suffering more than those areas that are considered urban. In other words, all those changes will affect the client's experience and as well the satisfaction they have in the healthcare provided. So the cost-driven changes have not only negative effects, they have also positive effects. Um, so let's describe one of them. In an effort of reducing the redundancy of healthcare services and to trying to increase the economic leverage, the hospitals and other healthcare facilities are joining together and are forming networks that are called Integrated Delivery System, or IDS. The IDS, the Integrated Delivery Systems, will provide a full range of healthcare services, and the main goal is to have a highly coordinated and cost-effective care. So there will be mandated shorter hospital stays, and as a result of that, will be fewer hospital-acquired infections, nosocomial infections, or complications for what that matter. And as a result of that, a quicker return to self-care. The nurses have a greater ability to take an active role in advocating for high-quality services, and the nurses that work in this new and expanding position in healthcare industries are highly trained for it. Implementation of the healthcare reform had many benefits. However, there are some concerns that they were raised along the way. Paying for the reform is complicated and controversial. The tax credits for small businesses and increased health insurance premiums and high deductibles, and the fact that there is a requirement for most Americans to buy health insurance or face penalties will provide some of the revenues to pay for the healthcare. Individuals and families may find easily qualify for subsidies in sliding scale tax breakers. The healthcare reform continues to be, however, a major challenge for legislative consumers and taxpayers in terms of how this will be implemented. When we are talking about healthcare and when we are talking in general about delivering services, we need to have a way to measure the quality of this care. And there is a demand for evidence that hospitals and practitioners provide high quality and not only or just cost-effective care. And this demand comes from the insurers and from other regulatory bodies, such as the Joint Commission. And not the last on the list will be us as consumers. We want to know what type of healthcare we will receive when we are asking for a service from a specific provider. So in order to meet those demands and keep up with them, the hospital have what is called a performance improvement committee. And those are groups or even departments where they are defining what is a quality service. And based on that, they will develop plans for quality improvement or in other words, they are committees that will look at the outcomes. They will use what is called standardized indicators. And one example of a standardized indicator is the quality indicator, or QI, that is provided by the Agency for Healthcare Research and Quality, AHRQ. These IQs may be used to measure healthcare quality at several levels. It can be seen as a federal quality, state, or local levels. Most specifically, they will be used at the level of the hospital, and they will have some kind of similar tools. In the AHRQ, the QIs will be made out of 4 modules. They will look into prevention QIs that are measures used by the hospital inpatient discharge data in order to identify the hospital admissions that could have been avoided through some kind of high-quality outpatient care. We have the inpatient QIs that will look into the quality of care inside the hospitals. And when we are looking at this, we are judging the inpatient mortality for certain medical conditions or surgical procedure. The third one will be the client safety QI that reflects the quality of care within hospitals, but has a focus on those potentially avoidable complications and adverse events as a result of the hospitalization. And we have what is called a pediatric QI that measures the data referred to identifying those potentially avoidable hospitalization among children. Now, when we are talking about the quality care measures, we need to mention here the Joint Commission. And this is because in 2002, they established what is called the National Patient Safety Goals. And those are goals that are updated annually based on the data that is existent in the previous period. The goals are established in order for all those accredited organizations to address their areas of concern, specifically related to client safety. For example, for 2016, the following safety goals were identified. To identify clients correctly, to improve staff communication, to use medicine safely, to use alarms safely, to prevent infection, to identify client safety risks, and to prevent mistakes in surgery. Now, other methods of determining the quality of care will be the client satisfaction surveys, the quality of life questionnaires, functional assessment tools, number of hospital admissions per year for clients with chronic illnesses and morbidity, and mortality rates as well. To finalize this presentation, we'll look into the future trends and goals for the healthcare system in the United States. And it is obviously that the healthcare system will continue to respond to any kind of changes that happen in our society. And when I'm talking about changes, those changes can be a wide variety. They can refer to demographics or cultural diversity. They can be related to technology or to, let's say, impact of the shortage of nurses. It is expected that our population, for example, will increase, population over 65 years of age will increase by at least 20% in the next 5 years. In addition to that, it's expected by 2030 to have about 40% of the population belonging to a certain ethnic minority. So there are some concerns that are related to the health of the American society as a whole. And there are certain initiatives that will are directed to promote health and monitoring the progress toward achieving health goals. If you will follow and look into the Healthy People 2020 campaign, there is an overall action plan to improve the health and quality of life for people living in the United States. And I will just give you some of the goals of this campaign. Will be attain high quality and longer lives free of those preventable diseases, disability, injuries, and premature death, to achieve high equity and eliminate disparities and improve the health of all groups, to create social and physical environments that will promote good health for everyone and to promote quality of life, healthy development and healthy behaviors across all life stages.